These are my disclosures. Short about the GYNOP registry. The registry covers all gynecological surgery in Sweden. The coverage is above 90%, and the patient's response rate is also above 90%. And we have a preoperative data 8 weeks after the surgery and 1 year after, collected from the patient. The aim of the study was to give a quantitative description of patient-reported complications at the 1-year survey for mid-urethral slings in Sweden. The material was 4,160 cases operated in 2017, distributed as you see. 16% either reported a complication, felt worse than before, or were unhappy with the result of the surgery. And out of these, 578 women used the possibility to comment on their problem in their own words, and this is our study group. Here's a short example of different definitions of complications in the GYNOP registry, and I used the GYNOP registry's definitions for complications. The main types identified were disturbed micturition, about 200 cases, pain, nearly as much, infection, wound dehiscence and scar problems, and the rest. The disturbed micturition was mainly urgency, impaired emptying or urinary retention, which is defined as using of a catheter, urinary incontinence worse than before, and a little bit of pain. The pain in a detailed analysis was mainly groin pain, totally dominated by the obturator techniques, dyspareunia, wound pain, abdominal pain, totally dominated by the retropubic approach, painful micturition, and a little bit of constant chronic pelvic pain with no localization. Infection was nearly only urine tract infections. There was 1 case of septicemia. Hemorrhage was very rare in the report by the patients, but 1 case was an intraabdominal bleeding that led to laparotomy. Organ damage was mainly vaginal mesh exposure, but it was less common than I expected. A little bit of nerve damage defined as sensory loss, not as pain. Those are in the pain group. And there was 4 cases of bladder perforation and 1 case of damaged urethra. These were the general complications identified, 1 case each. And this is the final interpretation of the patient's discomfort that was persistent after 1 year. And 408 patients had persistent discomfort due to the surgery. 130 patients did not have any problems at all. And in 21 cases, it was unclear if the problem was related to the surgery. And in 19 cases, it was definitely not the surgery that they complained about in the inquiry. The most disturbing finding for me was this one. In the end, the surgeons are asked to give the interpretation of the complications. And we have the last 2 columns is the women and the author's interpretation. And they overlap pretty much. It's only 52 cases that we decided was not a complication. Whereas the first rows are the surgeon's interpretations. And there you see that all the serious complications are gone, except 13 cases. And in 338 cases, it was interpreted as no complication at all. So the conclusions are that complications due to incontinence surgery are more common than generally anticipated. 10% of women experience persisting discomfort 1 year after the surgery, and surgeons seem to often disregard women's opinions about complications. And the reasons for this is something that we must study. Thank you very much.
So thank you for your presentation. The paper is now open for discussion. If you have any questions, there are microphones here.
So if I may, you've suggested that the women are not either disregarded or not heard in your interpretation, but is that not your subjective evaluation of your results? Because you can't actually say that.
Excuse me.
So in your conclusion,
Yeah?
you said that women are not heard or even disregarded.
Yes. It's because of this picture that when you see the interpretations here...
Right, but that's a subjective impression of your data.
Yes.
You haven't actually been back and said...
No.
Right.
No, this is just, the next question, is it that way? So
Thank you.
I have a couple of sort of simple questions. You started by saying that 90% of the people, of the women were covered by the registry, and 90% of the patients responded.
Yes.
So that means about 80% of the total cohort actually responded. Is that correct?
That's correct,
Okay.
yes.
Then the second question, I was a little bit, I thought this was well done, and I didn't think I was going to have a question when I read your abstract, because it looked like the complications were very, very low. But then in the presentation, you said that, I mean, a significant number of patients had, and what you described was discomfort. And the question that I have is, can you give us a sense of how many of the patients, how many of the women actually had problems that they considered to be a significant ongoing problem? I guess that's my question.
Yep. Yes, this is the 102 cases that I identified. The problem is that this is the women's opinions, and they often maybe don't really know what is a complication. They don't know the definitions, so it's just their feeling.
And the 102...
This is when I follow our guidelines in the registry, which and there is a subject for interpretation for that, because the most common reason why the women get here is because they have persistent or daily discomfort in their daily life. So when you have before the surgery you have urinary incontinence sometimes when you train, and after the surgery you leak every day, then your situation changed, and maybe the woman doesn't regard that as a serious complication, but it's a daily change of her experiences. You will see in the next presentation what the women say about this.
Does the next one cover satisfaction?
Some of these women were totally satisfied.
Because I think that we're missing the point, especially with stress incontinence surgery, where we know that only 2/3 are cured, but 90+% are satisfied. So I think satisfaction is really important, and you can't really interpret these results without a statement of satisfaction. So I would anticipate that many of these patients with so-called minor complaints would actually be satisfied because they were dry, thank God, and that was fantastic.
And that's correct. That's totally correct.
Do you think the register should actually carry the two questions that I think are important, which have been well validated, are if you're in the same situation again, would you have the same operation, and would you recommend it to a friend or an enemy? Not the enemy bit, but a friend.
Yeah, this question was in the registry earlier, but it has been taken away. The one about the registry.
Well, I think that's a shame, because we looked at that in a randomized controlled trial of two types of operations for stress incontinence, and that gave us this information that only 2/3 were dry, but 90+% were satisfied, which I think is really important.
So in true doctor style, I have some good news and some bad news. The bad news is if you are here to hear abstract 689 is not here, but the good news is Dr. Zacharias is not moving, and we're going to move on to his next abstract, which is what the women say, complications after stress incontinence surgery.
Yes, thank you very much.
Thank you.
Yeah, I have the same disclosures as before. The aim of this is actually the first part of the study, and the aim of this study is what do the women write when they give their doctor their opinion about the surgery. The method used was quantitative content text analysis clustering. And the main clusters identified were pain, urinary problems, sexual dysfunctions, infections, and exposure or scarring. Now the women will talk to you. Urinary problems were, I had problems at once after the surgery. I couldn't pee and had to use a catheter, and I still can't pee. I can't pee while sitting. I have to stand up to be able to empty my bladder. I use diapers, my urine runs all the time. Or before the surgery, I leaked while exercising, sneezing, or coughing. And now if I do not void immediately, I pee my pants. Pain. Pain 24/7, mostly on the left side, sensitive to tight clothes. They give more pain. At certain positions, when I sit or lift my leg, pain strikes my groin. I am always affected by the pain. I have difficulties to sit, a feeling of pressure over the urinary tract. It feels like the tape is pulled. My life has become very limited due to the operation. Or simply, did you hammer nails into my pelvis? I can hardly sit. Influence on sexuality. I leak a lot of urine during intercourse. It's very embarrassing and I stopped having sex. I did not have these problems before the surgery and I'm terribly sorry about that. I don't want to stop having sex at the age of 47. My sex life is much worse now. Since the operation I have difficulties to orgasm. During intercourse it hurts. If I had known about the consequences for my sex life, I would have declined the operation. Or I have no more sensation in my vagina. I don't feel anything during intercourse. But also the other way around. Spontaneous orgasms at night for 6 months after the surgery, and that passed over time. Recurring infections. Since the surgery, I had 12 urinary tract infections in 6 months. As soon as I stopped taking antibiotics, it came back. Then I got a 90-day treatment with antibiotics, and after that, I only had 2 urinary tract infections. Countless urinary tract infections, I suppose, because of the difficulties I have emptying the bladder. Or mesh erosion, or exposure, as I should say. I have 2 TVT slings lying open. I can feel it. It's sharp and scratches. These tapes prevent me from leading a normal life. The sutures opened up, and a bit of plastic could be seen in the vagina. I had another operation, and after that, something bulges in my vagina. Sometimes pain during intercourse. A sharp feeling down there. I got strange discharge, sometimes bloody, that I didn't have before. Once in the toilet, I noticed a blue fragment. And there's some mixed comments I want to present you. I got a mental crisis because my clear wish for a female surgeon was not respected. Nightmares and psychological problems as a consequence. This woman is totally cured of her incontinence, by the way, and happy with the result. Heavy bleeding, laparotomy, 12 days hospital care. See my journal for details. Complications occurred during operation. First, a bladder perforation led to a reoperation in general anesthesia. Now I have a 9-centimeter scar from the navel and downwards. There's a bubble-like thing near the navel that will be checked by a surgeon. So the conclusions are that a qualitative analysis of women's experiences can teach us valuable lessons. The treatment of some women suffering rare complications seems suboptimal, as they have persisting problems. And the preoperative counseling in regard to rare complications can be improved. Thank you for your attention.
Thank you. So this paper is now open for questions. Presumably this lady wants to get in the waiting list for the last lady's sexual questionnaire.
Well, thank you very much. Well, I agree with you that we must hear patient's own voice. However, pelvic pain can are very common among ladies without history of mesh operations, and well, they are influenced by preconceptions and prejudice sometimes. So, well, manufacturers-driven medicine is awful. However, media-driven medicine can be also a nightmare. In Japan, we don't have anti-mesh movement yet. So, transvaginal mesh procedure can be an option still. However, we have strong anti-vaccine movement, and due to media reports about chronic pain after vaccine, so now only a few girls have HPV vaccines, and it will cause the rate of cervical cancer in our country in future. And how can we balance these 2 aspects?
But that was a difficult question. But I think it's very important that we give the patients the right information, what they risk when they choose a treatment. In Sweden, we use, as you see, we use a lot of incontinence slings still. There's not so many alternatives that we do use, actually. But the most important thing, I think, is that give the patient the right expectations, and that she also knows what she risks by doing that.
Thank you.
Yes, Masa Nordqvist, the gynecologist from Sweden. Thank you so much for your presentations. And I have a question regarding both of them, actually. Did you separate the women that had gone through TVT and transarterious methods in an analysis to see any difference?
Not yet. I have looked at it, but it's not finished. As I told you, the obturator procedures were totally dominating the groin pain, and the TBTs were dominating the abdominal pain and the bladder injuries. But and all the other symptoms, there was no difference for the procedures. But the analysis is not finished in that.
So, Rufus?
Rufus Garrett, Oxford, UK. Was there much regional variation or variation between centres in women's subjective complaints? And if there was, do you think that's because of a difference in the rate of underlying complications or a difference in the way they were managed and counselled?
I'm not so sure if I want to answer that question. It seems to. But I didn't make an analysis directly on that, but it seems to.
Can I just one short question? Jonas Gunnarsson here from Göteborg. It's very valuable to have this information. It means that sorry, I must have hit this. It means that somebody has to go through these answering charts, read all the answers, and try to sort of cluster them and bring them all together. The value for us as a clinician is that we perhaps find a patient with a rare complication, but we don't know how often that happens to other doctors in other areas. And we really need the feedback from somebody like you who has actually looked at them and see if you could find that there are accumulations of rare complications that we probably as a single clinician would say, this is just nonsense. I'm not going to treat this. I'm not going to try to retract the tape because I don't believe in this. But if there is accumulation, even though they are rare, we need to know. So please give us feedback, not only in this setting, but also in the whole country.
You're right, and I think I should tell you that it was more than 300 surgeons operating on these 4,000 patients. So there's a lot of surgeons operating only a handful of patients. And maybe, of course, they don't see a serious complication for years. If you only do 5 cases.
So please publish it somewhere so that we can read it. Thank you.
Thank you.
So just a final point, Jerry.
I was asked to ask one quick question, and it's a rhetorical question for everybody. How often do you get these kind of responses with non-mesh surgeries? I'm just curious. Something scratching, poking in my vagina, chronic pain. List of hands. How many people think this is fairly unique to mesh? 2. I got my answer.
Thank you very much, Dr. Zacharias. And now we move to our next speaker.